Today's webinar is CAR T therapy for lymphoma, barriers and solutions to access. We chose this topic because CAR T is an exciting treatment option for lymphoma, but many patients have difficulty accessing it. We want to make sure patients like you are aware of these barriers and know how to overcome them so you have access to more treatment options. For today's webinar, we are very excited to have Dr. Marc Hoffmann join us. Dr. Marc Hoffmann is a board-certified hematologist and oncologist. He is the director of the Lymphoma Program and medical director of Lean and Quality Improvement at the University of Kansas Cancer Center. Dr. Hoffmann served as a Peace Corps volunteer in West Africa, then attended the University of Pennsylvania for medical school and residency, and completed a hematology and oncology fellowship at MD Anderson Cancer Center. Dr. Hoffmann is passionate about the development of novel therapies for CLL and lymphoma and serves as the principal investigator on multiple clinical trials. And with that, I will turn it over to Dr. Hoffmann for his presentation.
All right, thank you for the lovely introduction, Hannah. It's good to be with everybody this afternoon. If Hannah, you can just give me a thumbs up that you can hear me.
Yep, we can.
Awesome, looks like you can. I'm gonna share my stuff. Can you see? That's the next question.
Yes, we can see.
We can see, we can hear. All right, we've at least got 2 out of our 5 senses working. Now, is this gonna work? And there we go. All right, perfect. I was asked to talk a little bit about barriers and improving access to CAR T. I'm going to try and stay out of a lot of technical details, which, to be honest with you, I don't think are particularly relevant to your guys' understanding of this topic. But I did, it's sort of impossible to talk about some of the barriers without going through at least a little bit of the basics. So I'm going to assume that you know very little about CAR T cell therapy and sort of how it's actually performed. These are my disclosures. So this slide is a little bit complex, and it's not actually meant to be complex necessarily in terms of you guys understanding everything, but much more from the perspective of understanding that there's a lot of pieces to the puzzle that need to get fit in here. So in terms of the top pea green boxes, that's the real important sort of time frame to understand initially. So if I can focus your attention up there. What ends up happening is that someone has to recognize that there's actually an indication to receive CAR T cells. So a doctor needs to evaluate the patient and recognize that that patient may benefit from this therapy, and then actually make a referral in to a center that performs CAR T cells. For me, that's quite easy. I refer to my own center, but there's a large number of folks throughout our region and throughout the country that actually send patients in for CAR T evaluation. The CAR T process, generally most what are called standard of care CAR T cells, meaning these are FDA approved products that you can receive throughout the country, and this is not stuff that's on clinical trial. Those are something called autologous CAR T cells, and autologous just means your own stuff, right? So we're actually removing your T cells, and then they get sent off to a lab and get re-engineered to fight the cancer, and then they get infused back into you afterwards, okay? So the pre-infusion period involves a large number of different factors, right? We need to evaluate you, make sure you meet criteria, make sure your insurance company agrees, and then you have to undergo apheresis, meaning we actually have to pull the cells off. And then sometimes patients are sick and they're symptomatic from their disease, and so they need to get something called bridging therapy, meaning that they actually need to receive treatment between the time that they get their cells collected and the time they get reinfused, because we're worried that their cancer may get worse during that few-week time frame. So then the cells are infused, and there's this early post-infusion period where patients require a caregiver, which can impose some restrictions, and then they have an 8-week restriction on driving, which can also be problematic in this section. So then there's the long-term follow period where, to be honest with you, a lot of the short-term side effects of CAR T cells are not particularly problematic once you've hit that spot, but you do have a longer-term risk of infections, and there's some supportive care systems that need to be in place, and patients need to be followed on a long-term basis, not only for worrying about disease relapse, meaning that the lymphoma actually comes back, but also they need to be followed on a longer-term basis to make sure they don't get infections. So the bottom part of the slide is just meant to illustrate all of the different things that can happen that can contribute to a patient having problems. So this brain to vein time, meaning the time that I actually think that I'm going to give the CAR T therapy until it actually hits their veins, this covers a huge number of different things: insurance, referral bias, socioeconomic status, availability of a caregiver, and sometimes there's geographic delays in terms of you actually being able to get to the center. and that can all prevent timely access to care. The other piece on the other side is that what are the actual host factors, right? So what's going on with the disease in the patient? Have they had early and explosive relapsing disease? Is this a later relapse where they're generally doing a little bit better? How well are they doing from other standpoints? How frail are they? What are their other comorbidities? So all of these factors come into play. It turns out that in spite of all of this complexity, there's actually a number of very simple factors that dictate the vast majority of the reasons why patients have delays or simply just don't have access to CAR T. And so I'll get into that in just a second. All right. So this was a study that we did looking at CIBMTR data. So the CIBMTR is a registry of all centers that do cellular therapy. It was originally designated for stem cell transplants, but now we have a CAR T database as well. And this was just looking at what are the various factors that you can have. And so what you see on your left is a plot looking at these various factors. And basically, if something crosses and doesn't enter into this hatched blue line, what that means is that it's significant, okay? And that some patients may be overrepresented or underrepresented. So it turns out that you're more likely if you're a man to get CAR T cells. It turns out that you're less likely if you're Black. Other races did not have any statistically significant issues. There was no emphasis between rural and urban patients. Patients who were poorer, so anybody with a lower income status, was significantly worse off. And it didn't look like this was an effect that was just at the lower income strata, meaning those that were between 40 and 60,000. It was pretty much anybody who had made less than $100,000 a year, this is per household, had reduced access to CAR T therapy. And then there's this sort of Goldilocks zone in which people had some troubles, which was if they were between 2 and 4 hours from a center. I don't 100% know why that is. If you're more than 4 hours away, it's not a big deal. And if you're less than 2 hours away, it's not a big deal. But if you're between 2 and 4, that's a problem. I can't necessarily explain it. That's just what the data would bear out. So all of these are important pieces. However, by far the most important piece is just getting referred in general. So a lack of referral is responsible for the vast majority of adverse outcomes in cellular therapy. And why I wrote here that this is not a new problem, this is not data related to CAR T cells. This is data that we know about from a disease called acute myelogenous leukemia. And that particular disease, there is a curative intent therapy called an allogeneic stem cell transplantation. We have known for many, many, many years that the actual number of patients who are infused and who actually receive a transplant is only probably about a third to maybe a half, if you're extremely generous, of patients who actually should be transplanted. And by far the major feature is that those patients just simply are not referred. Now, over time, you can see that the difference between the estimated need and unmet need appears to be getting a little bit smaller. However, it's still pretty clear that the unmet need outpaces the estimated need, and this is also true in CAR T cell therapy. So this is not a new problem. It's something that we have to deal with. This was the unmet need for, again, that same disease, acute leukemia, for stem cell transplant. And this is basically just a heat map showing you where in the country do we have significantly reduced access. And so it's different depending on which parts of the world that you're in, but particularly in the Southeast, there's some challenges with referral access in a lot of the southeastern states, but it's not limited to that. More rural states such as Montana, and then some of the states in the Midwest also have significant access challenges. Okay, so what's going on with the actual number of CAR T cell therapies that we're using? Well, you can see here this is relatively explosive growth. This is the newest data that has been reported. There's typically a new set of data that comes out in the summer, and so we will probably have some of the 2023 and maybe 2024 numbers coming out. But it's obvious to see that there's a large number of indications. There's now multiple different diseases that can be treated with CAR T cells, and you can see there's an explosion in the number of patients that are actually receiving them. So what's actually going to end up happening? Well, it looks like, and if you look here, this is looking at third-line diffuse large B-cell lymphoma. I'll explain what that means in a minute, versus second-line diffuse large B-cell lymphoma. What we mean by third and second line is if somebody receives a course of chemotherapy, that's called their first line. If they've only received one line of therapy and they're treated right afterwards, that's second line. If they've received 2 courses of treatment and then they're treated, that's the third line of therapy. So interestingly, we start out at around 30% and pretty much stay there. And the same thing is true of second line. And you can see there's this sort of explosive growth kinetics, but then if things kind of level off at about a third. meaning that of the patients that we believe should be eligible to receive CAR T cell therapy, it starts to really plateau once you hit a specific growth curve. And the main barrier to that is just simply access. So some of it is awareness among referring doctors. Some of it is a capacity among academic centers and other CAR T centers to receive these patients. A lot of it, though, boils down simply to relationships that need to be built and maintained between CAR T centers and the referring physicians that are sending us patients. So this is an overview of the management back in 2018 for large cell lymphoma. And what we had at that point in time is that patients got chemoimmunotherapy, and about 60% of those folks with large cell lymphoma would get cured. If they relapsed, they would get second-line chemo and a possible stem cell transplant. If either that second-line chemo didn't work or they relapsed after the stem cell transplant, that's when CAR T cells were utilized. So this is the third line of therapy. And so this is just simply the management paradigm that we used to have back multiple years ago. And so the CAR T cells, when they were first approved, they were approved in this setting. And then we didn't do so hot, right? So this is just simply a group of folks, and you just basically crunch the numbers. This was the estimated number of cases. This is the number of people who weren't cured. This is the group of people who were uninsured. This is the group of people who had insurance. And we would estimate that about 3,400 of those patients should have received therapy, and we only infused 700 of them. So we knew this was a problem back then as well. And it's mainly just simply an access and referral issue. In current management, right? So there have been two large randomized studies which both showed a significant survival benefit, right? Where patients received R-CHOP or similar. The 40% or so who were not cured and ended up in this red box, they were randomized to either get an intent to transplant versus a CAR T cell. And there were three studies that were all done at the same time. One of them turned out to be negative due to some methodological issues, but the other two showed a very clear survival benefit to CAR T cells compared to transplant. That survival benefit has persisted over time and is new and demonstrable. This is very much the current standard of care that we have. There are other drugs that are currently being developed that are intended to potentially compete, but I don't think we're going to see much in terms of randomized trials against CAR T cells in the second line setting. And so this really is established as the second line. Well, we have the 2018 math. What if we do the modern math? Well, if we do the modern math, what you can see here is that we're still behind, right? We should be treating at least 4,000 folks with second line CAR T and probably 3,000 with third line, and we're only treating 1,200 in the second line and 500 in the third line. So this is still very much a problem, and this was data from 2022. Again, the data updates in the summer, and so I anticipate getting some updates this summer on this. But we're not doing a whole heck of a lot better in spite of having had 4 years to try and optimize things. Okay, so the impact of referral alone. All right, so let's pretend like we cure about 35% of patients with CAR T. That's probably an underestimate. It's probably maybe a little bit higher than that. But if we take that conservative estimate, if all 4,000 eligible second-line patients were actually referred and received CAR T, we would have almost 1,000 patients that were in long-term remission, and we would we would more than double the rates of cure simply by using existing therapies, right? So underutilization of services is responsible for by far the biggest magnitude of impact, right? We can improve the CAR T, we can improve patient selection, we can do a number of things in that regard, but we can more than double the patients that are cured just by getting them into our centers so that we can actually treat those patients. So what are some of the barriers? I think you guys can probably think through this. It doesn't require a medical degree to understand this. So I think the biggest piece is just prioritizing and optimizing relationships with referring doctors, right? So what I learned was that there were 3 A's associated with being a good consulting physician, right? Availability, affability, and ability. You notice ability is the third one in the setting. I'm not saying you want a doctor that's not particularly able or can't do their job well, but it turns out that being available and being nice to people is more important than how good you are at your job. And that's specifically true in terms of a referral base, right? So one of the things that we're constantly trying to do from a relationship optimization standpoint is sometimes we have new recruits, and these are young doctors, and sometimes their social skills are not quite up to snuff. We're trying to get them out to the point where they feel quite comfortable calling our referring physicians, making sure that they create those networks so that they're getting a lot of referrals coming in, and that we're also referring patients back out to some of those folks that live out in rural areas when we have patients that are at our center that really would be optimally treated much closer to home, right? So these relationships need to be bidirectional. You absolutely have to send them patients if you're planning on getting patients from them. And we just need to make this access easy and to make sure that those patients, right, again, you're available and that you're affable, right? You have to be nice and you have to be available. Unfortunately, that's probably more important than how good you are. Now, it's obviously ideal to be all good at all three of those, but I think that being available is something we can correct. Being affable is something we can mostly correct, and being able is something we can improve upon. So I think all of these things we could do quite a bit better of a job of. Some of this is a lack of knowledge among referring physicians, right? So there are a number of doctors who trained during the era of stem cell transplantation. And I'll be perfectly honest with you, if you were at a center where stem cell transplant was not done regularly or not done particularly well, you can leave with some challenges after that. A stem cell transplant that does not go particularly well can be a really problematic thing. And a number of doctors may be understandably reluctant to send certain patients. So a lot of this is getting people to understand that this is not the same thing as an allogeneic stem cell transplant, that these patients in general are not going to have anywhere near the number of side effects and toxicities that are associated with therapy, and making sure that they promote this among their patients, right? Most patients are interested in doing what their doctor tells them is the best option. And so we need to make sure that these referring physicians understand that this is the ideal treatment option, this is curative intent, and this is available. And we also need to simplify our process, right? So it's a simple phone call when they need to get a patient in. We make sure that that patient gets in a timely way. We make sure they get taken care of quickly. And then in the post-CAR T setting, we make sure that it's easy to follow an algorithm. We provide them with information. These are the labs that you need to check. These are the things that you need to do in terms of making sure that the patients don't get infections and don't have other complications from the CAR T cells. So patient resistance, and this gets in a little bit to the lack of knowledge piece, right? But when we have a patient that's on the fence, if the doctor gives a really strong recommendation, says you really need to go meet with them and talk to them about what this therapy is before you say no. A lot of times we have patients come in who are understandably trepidatious. They're a little bit worried. They don't necessarily know what CAR T cells are, and they need to understand and have a little bit more of a context for it. And a number of them still decide to receive CAR T cell therapy. Sometimes they decide not to. And I'll be honest with you, sometimes it's not the appropriate therapeutic choice for a particular patient. But I do think that they need to at least meet with us, have that discussion, understand what it is that's being recommended, why we're recommending it, and what things would look like if patients elected to do that. And then the other piece, and this is something that I certainly own on our side, right? So poor communication from receiving centers. So this is centers that are doing CAR T cells. If we don't adequately communicate back to our referring physicians what's going on so that they can take care of these patients, that's a really big problem. We, again, try our very best to do this. This is something that we actually discuss repeatedly in faculty meetings, and make sure that doctors understand that this is the expectation, right? If you're sending a patient back, it's a warm handoff, it's a direct phone call. This is something that we're having a clear discussion on to make sure that these patients get taken care of appropriately. Right? If that's not happening, you're not going to end up with good outcomes. And to be honest with you, if I were a referring doctor and the people that discharged my patients didn't call me and let me know what went on with them, I wouldn't be particularly happy with that service either. All right, so this is a guy named Krishnamurti. He's sort of more of a spiritual person than anything else, and we don't necessarily need to get into a spiritual realm, but what he wrote here, I think, is incredibly important, right? Everything is happening in the context of a relationship, referrals, making sure that you have timely access. This is all about relationships between a variety of people, right? Referring physicians and the receiving doctors in the CAR T center. But then it's also about what are those relationships with those patients, right? How do those two groups interact with the patients? How do we make sure that there's harmony there, and that everybody accepts the appropriate set of responsibilities, right? There are certain things that we need to be doing as the CAR T center. There's certain things that they need to be doing as the referring center. And there's certain things that we expect patients to be able to do in order to make sure that they achieve a good result. Okay, so how do we do some of this? Well, this is just some random texts. Don't look into all of this. I tried to eliminate all of the names on this, but these are just some random texts that I received from a variety of different doctors. Everybody has my cell phone number that lives within a relatively recent radius. We get into all sorts of interesting conversations, and you can see there's insurance discussions in here, and there's a variety of other things. But I get a text, I get a phone call from a doc that needs somebody sent in for CAR T cell evaluation. We're bringing them in. I'm getting that done. I send an email out. There's a whole army of people on our side who all they do is deal with access, right? They find who the patient is, they collect all their medical records, they get them scheduled for an expedited visit. We typically see these patients in 72 to 96 hours in order to make sure that we can capture all of these folks that may have rapidly progressive disease. So this is all just communication, right? This is basics. We're not even talking about all of the space age science here that it took in order to re-engineer a T cell, which normally fights off viruses in order to kill off a lymphoma cell. So this is just some data from the transplant literature looking at the importance of early testing and referral. Okay, so again, what we're talking about here is not necessarily lymphoma. I'm going back a little bit to that acute leukemia transplant piece, but it turns out if you send people early for a transplant discussion, right, it actually improves the likelihood that they're going to get a transplant. So early and often we want to see these folks, make sure that we recognize them. I am sometimes referred patients who are actually in complete remission, but the doctor believes they may be at a high rate of recurrence. They want to make sure that we know the person and that we've had a discussion with them about what might be coming down the pike if they were to relapse. These are related to stem cell transplantation, both what's called autologous, meaning the patient's own blood for transplant, as well as allogeneic. This is just a simple outreach protocol, right? This is a group of people that decided that they were going to attempt to reach new communities, and they had a dramatic increase in transplant referrals. And interestingly, it was more prominent among underrepresented minorities compared to white patients. So it turns out it does matter, right? Communication and going directly out to people's home base and sharing with them that you're available is helpful. How about some geographic barriers? Okay, so these are things where the travel to and from the CAR T center can be problematic, right? I live in a relatively rural state. It takes about 7 hours to drive all the way across Kansas, and some of you may have experienced this. Generally, it's experienced when people are driving to Colorado for the summer vacation, and Kansas is a kind of a fatter state, and it takes a while to get across. Well, that's just if you're on I-70. If you're going way down into rural Southwest and outside of Dodge City, it can take up to 8 hours to get into Kansas City. So this is an issue. We probably need more CAR T centers. They need to be more strategically placed, not just where people decide to make them, but maybe putting them into places where things can go. It turns out there's travel reimbursement that's available for a lot of CAR T cell companies. And so a lot of the pharma companies that make these cells have some money that is available to help assist patients with travel. That needs to be more streamlined, less variable. We need to have some better ideas there. Local lodging at CAR T centers. I'll show you some photos of our local lodging center. This is true in a number of different centers. There's some places that have fairly large hotels. It's often compensated actually either for free. Ours is done through philanthropic funds, and then sometimes it's done through actual insurance or sometimes through the CAR T companies themselves. And then the question is, do we need to monitor people for 30 days? I'll show you some data that suggests that we may not do, right? So it's not just the fact that they need to be lodged locally, it's they need to be lodged locally for a month, right? So if it were 2 weeks instead of a month, that would probably be a much easier thing to do. Caregivers, this is huge. So this is something that's a really big deal. When we have patients that are receiving this therapy, we do require, just due to some of the unusual complications, that someone's available and around and with them 24/7 in case they have fevers, in case they have some alteration in their mental status, so that we can get them potentially admitted to the hospital in short order. Part of this is that some people don't have anybody. So there's a non-negligible group of folks that I work with. They don't have anyone that they would consider be a caregiver. Now, it turns out if you ask them a couple deeper questions, usually you can find someone. And I'll be honest with you, I've never had somebody where we simply could not find a caregiver. Sometimes the patient doesn't want to use that person or there's some issues, but usually we can find somebody. a friend at church, a friend of a family member, something along those lines. But that person can have some challenges, right? They are not working for free, right? Caregivers are not compensated necessarily for their time at this point, so that could be something that's there. Sometimes patients or caregivers may not be able to move, right? So you have a job, you have to live somewhere, you're not able to take time off of work and physically move. Sometimes people can work in a remote fashion, but sometimes they can't. And then there's cultural barriers, right? So most CAR T centers are in urban areas. This is something I notice all the time. I have patients that are used to living in their two-stoplight town. They come here and they think the traffic is unbelievable and everything's overwhelming. And it's interesting for me living in Kansas City, having lived in a wide variety of much larger places where the traffic is way worse. My attitude is always, wow, it's great here. But for them, it's a very, very different experience. And so having folks in here getting over some of those barriers can be a problem. The other thing, and this is actually, it's interesting, I did some work in Spain, actually, and what we found, Spain is a much smaller country, right? Spain is basically the size of two Kansases. And so it's got about 125 million people. So the population density is much higher. It's pretty easy to get around. But people there were very provincial. They didn't want to go more than an hour, hour and a half. And interestingly, they had a lot of the same misgivings. They sometimes didn't want to change teams. They liked their local doctor. And so it was interesting to see that some of the main things that we think of as being geographical barriers that are just simply due to the large size of the United States, those things persist in other countries with higher population density, where the distance that you have to travel is also significantly smaller. And so there's clearly pieces to this puzzle that are not specific to the actual distance itself. So this is the number of CAR T centers. This is just a simple map you can see here. Number one is us. We made the map, so I get to make myself number one. So garara for us. But you can see there's just large chunks of the country that are not well represented. And so it's not surprising that access to cellular therapy in the southeast over here, some of the southwest, and then up here in Montana and the Dakotas is somewhat limited, right? It's a long way that you have to travel from there if you need to get some kind of cellular therapy. Okay, so this is the Hope Lodge. This is a nonprofit that's run through the American Cancer Society, that's run through philanthropic monies. Patients do not pay to stay here, but they receive access to a kitchen. So they largely are cooking their own food while they're there. And so there's a full service kitchen that's available. And then they have basically what looks like a hotel room. There's phone service, there's internet service. And so this is a relatively straight way. You notice there's two beds, right? One for the patient, one for the caregiver. And so sometimes patients are not spouses, right? It's a sister, it's a brother, it's a child who's the caregiver. And so we have this space that's able to accommodate these patients. How about some of the technological and delivery barriers? You can see here, this is from a paper that we wrote that was looking at this. All sorts of issues based on referrals, reimbursement, the fact that CAR T is only available at certain centers, production slots are limited. We have delays in manufacturing, meaning that you go ahead and send the cells out and maybe the company's had a run on CAR T. And unlike old time treatments that were basically pills, where you can ramp up production essentially to meet demand whenever you want, you're just making more pills. In this case, the manufacturing cost and the manufacturing complexity is non-negligible, right? We're not making pills, we're actually taking in cells and re-engineering and remanufacturing them. Needs for hospitalizations, referring physician skill set. So what I mean by that is how much do they know about the disease? How much do they understand what's going to happen? And then long-term dealing with the low blood counts, infections, and then what we call B-cell aplasia, which is a complication that requires patients to be on IVIG in order to prevent them from getting infections. So what are the things we can do? Well, we can streamline reimbursement. That's already happening. Outreach by pharmaceutical companies. So I think pharma sometimes gets a bad rap in this process, but this is definitely something that pharma can do and can do a really good job of. They can help facilitate outreach. They did a wonderful job. The company that made the very first CAR T cell that was FDA available, they did a really good job for us of helping us connect to some of the local physicians, setting up programs, setting up dinners for us to be able to sit down and have these discussions and create these relationships. increased apheresis capacity, right? So this is just talking about how do we actually pull this out. There is something called an allogeneic CAR, which is that you get a T cell from a healthy donor, and that's available, and that's something called an off-the-shelf product. We actually were the one of the larger centers in several of these off-the-shelf products that have gotten presented recently. They work. Do they work as well as the autologous constructs? Not entirely clear that we're quite there yet, but we actually are getting them to actually to work. We have an off-the-shelf product. You're no longer necessarily needing pheresis. You have a less time that you need to bridge these patients. So that's a potentially really cool way that you can do this. And then a lot of this is just education and, again, approvals that we can receive for specific drugs. I won't necessarily go into that. This was a talk that I gave to a more medical-oriented group, but just leave the hold that there are certain drugs that we like to use in the post-CAR T setting that can help prevent problems. And sometimes those drugs don't actually have an FDA indication, and we can have challenges getting them through insurance. And then the last piece I was going to put in here, and you do not need to pay attention to all of this, but the concept here is if you look at the people that are on this, right? The green people that are dark green and the blue people that are dark blue are people that actually had a problem. And all of the light blue people are the people that didn't have a problem. And the interesting thing is what you notice is that almost all of these happened between day 0 and day 14, right? So this is the first group is the first week, second week, third week, fourth week. We currently are requiring patients to stay for 4 weeks. Do we need to do that, right? The rate of complications is 0.1%. Probably don't need to do that. Do we still need to monitor for 30 days? I would say no, based upon this data. Now, for novel constructs where somebody's on a trial, we don't know necessarily what that's going to happen. That may be a slightly different story, but I think for your garden variety standard of care CAR T patient, probably don't need to have this extended monitoring period. All right, so some take-home points. This is mostly a people problem. So we can call it a people problem. I like to say that there was an economist way smarter than I am who said that the hard problems are easy and the easy problems are hard, okay? What do I mean by that? Well, the hard problems are the ones that are hard to even explain, right? It is hard to create a combination of things where we pull T cells out of a patient, we knock out certain parts of the protein that are on the outside of the cell, we put in new proteins, we do all that in a context where it is up to medical grade in terms of the reliability and the fidelity of that process. And then we ship those back in and infuse them into patients, and we end up somehow miraculously making a difference. That's a hard problem. Well, it turns out that was, I don't know, it took the efforts of a lot of people, but we figured it out. Okay. We still have not figured out the same problems we've had since the 1970s, which are the easy ones, which is how do we actually just get the patients that need it access to treatment, right? I showed you the data. We would have an over 200% increase in the number of patients who were cured if we just got them to our center. Okay. So this is part of this. This is our problem as the CAR T centers. This is not the problem of everybody else. We have to make sure that we are doing the best we possibly can in order to get all of these folks out here. Prioritize and optimize relationships, right? So if you are not looking at relationships, you're looking in the wrong space, right? You have to create relationships with other people. You have to make them functional. You have to make sure that they're win-win. You have to make sure that they're done on a respectful basis, right? What are the referring providers getting out of this relationship? That needs to be part of the conclusion here, right? So we need to make sure that these things are done equally, that they're done on good footing, and that people can maintain these relationships over time. And then the last piece is just making it less of a hassle, right? So it's a pain to do, right? Somebody has to come up, they have to talk to me, they have to get pheresed, they have to get manufactured, they're in and out, they're back and forth. A lot of the times they don't necessarily want to have to come down here. If they live a long way away or have some degree of limited mobility, right? They require a cane or a walker or something like that. This can be a really big deal. And I have aging parents, and taking my mom out to dinner doesn't take, it takes quite a bit longer than it used to, right? It takes longer to get her into the car. And you got to get out of the car. You got to make sure you're parked somewhere where she can get there. This is all stuff that we need to consider when we're thinking about it. And so that's basically what I had for you guys today. I will stop sharing. And I think I did this on time, Hannah. Am I right? You told me 40 minutes and I took 38.
Yes, perfect. Thank you. And thank you for that wonderful presentation. So now it's the time for the discussion part of today's webinar. So if any attendees have any questions on today's topic, Now is your chance to ask those questions. This time is specifically set aside for our community members to have a chance to talk to our incredible presenters. So please feel free to ask your questions if you have any. And okay, so one question is, what is the likelihood of relapse after CAR T?
So it depends on the disease, right? So diseases, probably the best studied disease in this is diffuse large B cell lymphoma. And in that particular disease, it's about a cure fraction of somewhere in the neighborhood of 35 to 40%, right? So meaning for everybody that comes in, about 35 to 40% of those patients are cured of their lymphoma. The likelihood of relapse is actually a little bit less than that because unfortunately we do lose some patients to toxicity, meaning that some patients unfortunately die of complications related to CAR T cells. The vast majority of those are related to infections. Unfortunately, the infection risk is both acute, meaning when the patients are infused, and then there's a longer term infection risk that patients can get later. That longer term infection risk, I would say, from a medical standpoint, other than just making sure that the CAR T cells actually work better, but I think that long term infectious risk is probably one of the biggest medical ways that we can improve the long term efficacy of the disease. A lot of those infections are preventable, right? These are things that you can prevent with vaccines, that you can present with administration of prophylactic, either antibiotics, antivirals, or other drugs such as IVIG. The likelihood of relapse after CAR T in a number of other disease states, it really depends on which it is. So follicular lymphoma, mantle cell lymphoma, CLL. Unfortunately, those are diseases where, in general, they are not felt to be curable without an autologous stem cell transplant. And so, with an allogeneic stem cell transplant. And so as a consequence, it's sort of hard to let you know exactly what those numbers would be. And we need much longer term follow-up. But we do think that there's probably patients with diseases that were previously not felt to be curable without an allogeneic stem cell transplant who are probably cured with CAR T. We just don't know that yet, and because you got to watch them for a really long time.
Perfect. Thank you for that answer. And then another question is, I've heard about CAR T, but I'm nervous about talking to my doctor about it. So what's the best way to bring it up to my doctor?
I would just ask them directly. I would just say that, hey, I've heard about CAR T cell therapy, and I'm wondering if it's something that I could do. Who would you refer me to? Sometimes they may say, oh, you don't need it because of the following things, right? You're in remission, everything's going fine. Sometimes they may say reasons that they may not want to do it. I would say that most good physicians are going to have someone that they rely on to talk to about doing CAR T cell therapy for a variety of patients with lymphomas, and now they're available in multiple myeloma as well. And so a lot of community practice doctors should have relationships with someone at a CAR T center. So I would say just bring it up. I can understand the anxieties of it. You don't necessarily want to appear to be questioning what your physician's decisions are, but I think it's perfectly reasonable. I have patients that ask me questions all the time about things that they heard about. And it doesn't bother me, right? I may tell them the reasons why I wouldn't do it. So it may be not appropriate in that context. And yet at the same time, sometimes they bring things up, and it leads to a discussion where maybe something I was thinking about anyway, and just for whatever reason had yet to discuss with them. More commonly, the question of what they're asking about a specific therapy leads to me having a deeper understanding of what their priorities are and what they want, and allows me to better match what we're doing with what they're interested in having. And so I think it can be a nice moment to sort of make sure that that alignment has taken place, where what's being recommended that you do and what you want are much more intertwined. And I guess the only other thing I would say is I feel like you deserve that as a patient, right? That's something that as a patient, you deserve to receive therapy that integrates with your life and integrates with your values. And that's the most important thing. I can certainly say there's plenty of patients that have not done what I've recommended to do for a wide variety of reasons. Most of the time, we are then able to find an alternative solution that I at least find acceptable. It may not be what I think would be the best thing for them in terms of controlling their disease, but controlling their disease may not be the most important thing in their life at that point. And so there's a lot of different ways that this can unfold. But I think having the discussion is certainly the first step.
Absolutely, thank you. And then I know you're a lymphoma expert, but another question we had was, is this approved for AML or any other blood cancers that you're aware of?
Yeah, so currently the approvals are for multiple myeloma, a variety of different kinds of lymphoma, a disease called CLL, and CLL stands for chronic lymphocytic leukemia. That's also actually a lymphoma, by the way. Just being a lymphoma guy, I got to plug out biologically, it's a lymphoma, which is part of the reason for the approval. So um, acute myeloid leukemia has been a really challenging area in order to do CAR T. So there has been investigation in CAR T cells, but the two pieces that have made it challenging are there and something called T cell lymphoma. So it turns out all the lymphomas I've talked about are B as in boy cell lymphomas versus T as in Tom cell lymphomas. Our targets that we have are not specific, okay? Meaning that when we go after lymphoma cells that are B cells, we often kill all of the innocent bystander B cells in the process, okay? And so when you give a CAR T, at least right now in our sort of Ford Model T model, when we get upgraded to a Mustang with a spoiler and an electric engine, maybe it'll be able to differentiate between the cancer cells and the non. But we're actually eradicating a large grouping of cells. Okay. So why is that important? Well, you can live without B as in boy cells. You cannot live without T as in Tom cells. And then AML, the myelogenous group, the myeloid lineage, is responsible for making granulocytes, which are neutrophils, and platelets and red cells. Well, it's kind of hard to live without those things either. So there has to be a plan for how you'd recuperate. And so the strategy that's been used in T cell lymphoma and in AML, from a CAR perspective, has been more using the CAR to optimize disease control and then following that up with a transplant in order to have a recovery of the cells. So that's one technique. And then sometimes they have CAR T cells now that we can kind of try and turn on and off. And so there's this concept that you can either turn them down. Now it turns out ramping them back up if you may need them is complicated. But it's more of a target problem, right? Meaning that the granulocytes and the T cells are the target, and you can't live without those cell lineages, whereas you can live without B cells. And so B cell diseases have been the easier target to go after.
Perfect, thank you. And what barriers do patients encounter the most, and what can we do to advocate for ourselves in those situations?
Yeah, I mean, I think that most of the time, a lot of the people that I would say this, most of the people that are not getting CAR T cells are probably people that I don't ever see. Right. So that's the biggest issue is that a lot of times they're just not seen. And then sometimes they're referred in very late in their disease course after they've had several lines of therapy. And I'm wondering why they weren't offered CAR T, and they don't know either. And again, these are the only people that I'm seeing. And so sometimes, though, they've discussed CAR T cells with their doctor and decided not to do it. But I think a lot of it is just increasing awareness. Most of the time, when somebody's in and they're committed to getting therapy, we can find a solution for them, right? We can find a way that they can receive treatment effectively. We can figure out the caregiver issue. We can often help figure out the travel issue. Sometimes there's a certain percentage of patients that I expect just aren't going to be able to do that. But a lot of it's just getting in the door, right? Which I know sounds like an unsatisfactory answer, but it's definitely the biggest piece, and certainly the data that we have that's available on a lot of the disparities would suggest that that's true. Um, so I had spoken a little bit about social determinants of health and income and race. Um, this is a little bit of an extrapolation, but I think it probably still holds. The main reason that we don't have adequate participation in clinical trials for poorer patients and underrepresented minorities, and then rural patients are actually a large unmet need as well. A lot of them aren't offered clinical trials. So it's not just that they may not enroll. A lot of times they're not referred in, or if they see someone, they may not be offered a trial. So if I had a trial, and I'm not saying I do this, but if a doctor has a clinical trial available, they may not offer it to one of these groups of people and make an assumption that they're not going to enroll. Where there's actually a fairly sizable study that we have going on now through our cooperative groups. So these are studies that are funded through the National Cancer Institute that are answering questions where there's not a clear financial rationale for a pharmaceutical company to try and answer the question. And so they have to be done in publicly funded. But it's actually looking at every single person that is offered a clinical trial. What are their demographics? What's going on with them? And how did the physician dynamic occur? And so some of it's just that they're not offered, which I think is a real shame. But I think a lot of it is just them not making it through the door.
Absolutely. And another question is, I've read about CAR NK trials online. Would this have the same expected barriers as CAR T?
Yes, I mean, provided that it's something called an autologous construct, meaning it's removed, re-engineered, and then reinfused. The CAR NK cells, at least as of right now, are only available in clinical trial. The issue we've had with them, and this gets into a little bit of the technical significance, but it turns out that the most important factor that dictates whether the CAR T cell has an opportunity to work at all is something called expansion, meaning when it gets infused into your body, it has to expand really, really rapidly. And we've had some challenges getting the CAR NK cells to expand as rapidly as we would like. There have been some promising constructs. One of the main labs that's been doing this is Katie Rezvani's lab at MD Anderson. She's been doing a lot of work on NK cells. And I think we were very excited about them, but there have been some technical challenges. I think those technical challenges may ultimately get worked out. That's sort of where things stand from a CAR NK perspective.
Thank you. And then I think the last question we have time for right now is, are there any policy changes that can be made to help address some of these barriers?
Um, so I think that the short answer is I'm not exactly sure. I do think that probably the easiest policy change would be some sort of revision to our insurance structure to make it less complicated. There are a number of patients who I know either are not referred for CAR T or who do not consider themselves to be candidates for CAR T because of their insurance status. Those folks, it's pretty tough what do we do about that? They don't have a security net at all. We at our center, my hospital sits about 80 feet away from a road that's called State Line Boulevard that differentiates between Kansas and Missouri. Okay. So the hospital's on the Kansas side. You walk about 80 feet out of the hospital and you're in Missouri. I mean, I've been here almost 10 years. Up until about 2 months ago, we could not treat Missouri Medicaid patients. Okay. There was no contracting available there, and there was nobody sort of making sure that we would be able to treat it. So if you lived 150 feet from our center and you were a Missouri Medicaid patient, you had to go to a center in Missouri, which basically meant you had to go to St. Louis, right? Which is highly inconvenient. You could walk 150 feet and come to us, or you could travel 4 hours the other way and go to St. Louis. So some of these policy changes are insurance revisions. Even if we work within the same insurance protocols, how do we make sure that our public insurers have rational coverage analysis so that it's done more in a geographic frame rather than necessarily a state by state frame? And the same can be said of a lot of cities, right? A lot of major cities are on rivers, typically that make borders between specific states, right? Where, look at New York and New Jersey and Connecticut, like that's all jam packed in there. And you have to figure out how that's going to look. And so I think that there are some policy decisions there. But it's tough. I mean, I'm not going to sit around and wait for Congress to fix this for us.
Absolutely. Thank you so much for these informative answers and for your wonderful presentation, Dr. Hoffman.
You're very welcome. Thank you for having me.
Of course. And before we go, I wanted to quickly highlight our Connect groups. These groups allow you to connect with other patients like you. Once you're in Connect, you can join any of our other helpful groups, such as side effects and their solutions, treatment and testing, and nutrition and wellness to hear from other patients about their experiences. So you can scan either QR code on the screen to join one of our lymphoma groups, and the links to sign up for these will also be included in the follow-up email. I also wanted to highlight some of our exciting upcoming events. So on Thursday, we have an event to learn how you can volunteer with HealthTree regional care teams. Next Tuesday, April 15th, we have a podcast coming out about the DRIVE initiative for clinical trial excellence. And on May 1st, we have an event about treatment options for relapse following CAR T. So we have many more virtual and in-person events in the works, so stay tuned. The link to sign up for these events and many others is found at the bottom of this slide and will be sent out in the follow-up email. And finally, I want to say thank you again to Dr. Hoffmann for his amazing presentation, and a huge thank you to you all for helping us build our lymphoma community. I've added my email to this slide, so please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate you all and hope to see you at another webinar.